Hello again, everyone. Welcome to our second or third session for the morning. And our session is cardiovascular risk screening in general practice with Dr. Carissa Bonner. Before we start, I want to thank our sponsor for this session, who's Bristol Myers Squibb, and remember to pop into at the bottom there the sponsors. And also, before we start, just a reminder that Health Pathways, this talk relates directly what's on Health Pathways, which is an excellent resource that we can all use. So now I would like to introduce our speaker, Dr. Carissa Bonner. Thank you so much for taking the time to speak to us this morning. Dr. Carissa Bonner is a behavioural scientist working in public health with a focus on medical decision making and risk communication, which, as we know, is a hard thing to do sometimes. Her PhD at the University of Sydney investigated how GPs and patients make decisions about cardiovascular disease risk to identify ways to improve the prevention of heart attack and stroke. This led to her current role with the NHMRC Centre of Research Excellence, where she's developing new systems to communicate research evidence and shared decision-making resources to GPs and their patients. Very relevant to what we do in our job. Dr. Bonner has spent the last 10 years investigating psychological aspects of health through research roles in academia and consultancy, and has expertise in the development and evaluation of communication interventions used in clinical practice around the world. Thank you so much. Over to you, Carissa.
Thank you very much for that nice introduction, and thanks for joining me for this session. So as mentioned, I'm a senior research fellow in the School of Public Health at the University of Sydney, and my focus for the last 10 years has been on CVD risk assessment and management in Australia. But I work with a really big team of GPs across Australia to make sure that this work is relevant to GPs and other professionals working in primary care. So for this session, I'm going to be going over 4 different sections. The first will be a really brief overview of the guidelines, because I know most of you already will know this, but happy to answer any questions at the end if I've missed out on some details. Part 2 will be an overview of some of our Australian research on the barriers to current CVD risk assessment and management guidelines. Part 3 will focus on auto-populated risk calculators and decision aids as a possible solution to some of these issues. And part 4 will have a really brief look at future directions for CVD risk assessment in Australia and internationally, as these guidelines are currently under review. So for part 1, we had our current assessment guidelines were released in 2009, and corresponding management guidelines were released 3 years later in 2012. More recently, there's been an update for Aboriginal and Torres Strait Islander populations last year. And as I mentioned, the guidelines are being reviewed this year for release next year. So they're due in October 2022. So in terms of risk assessment, this is the original risk calculator that was made available to GPs in Australia by the National Vascular Disease Prevention Alliance. It looks a little bit different now. It has a nicer interface, but this was the original version, and it was supplemented with paper-based charts. So if you couldn't access the interactive tools that required an internet connection, you could use the paper-based charts instead. So some of you may have used those. So the basic premise for this change is that we used to look at blood pressure and cholesterol as individual risk factors, but research started to support this idea of absolute risk assessment as a better way to predict who is at high risk of a heart attack or stroke and who would most likely benefit from medication to reduce that risk. So the principle behind this is that we're combining modifiable risk factors like blood pressure and cholesterol with non-modifiable risk factors like sex and age to come up with a better prediction. So in Australia, there were some clinical decision support tools built based on this algorithm in 2009, but in 2012, the algorithm slightly changed. So you may be familiar with this PDF screenshot, but it introduced this idea of clinically determined high risk for certain patient profiles. So for example, if you have diabetes and you're over 60, you're considered to be high risk without the need to do the absolute risk assessment, and you're considered high risk enough for medication even if your absolute risk calculation came out as really low. So there's a whole list of those criteria that were not actually built into the risk calculators that were available in Australia. And that's something that we tried to address in the research I'll show you in the next section. In terms of management in Australia, we've got this 5-year timeline, but most other countries use a 10-year timeline. So our risk thresholds for medication are different from many other countries, where we're recommending medication for both blood pressure and cholesterol if the risk is greater than 15% over 5 years. So that doesn't necessarily translate into 30% over 10 years because different models are used in different countries, and I'll talk a bit more about that towards the end. In terms of other risk categories, for low risk under 10%, no medication is recommended, but we do have still some treatment of patients on the basis of their blood pressure or cholesterol if they're really high. And in moderate risk, generally medications are not recommended unless you've already tried lifestyle for 3 to 6 months, unless you have other risk factors such as a high risk ethnicity or a strong family history. So the management guidelines make it a bit more complicated than what the risk calculators show. And so last year we had this Aboriginal and Torres Strait Islander position statement. So this was a consensus statement amongst many groups, including the RACGP and the Heart Foundation. And the main change here is to reduce the age at which you assess risk for Aboriginal and Torres Strait Islander patients. So we're now recommending to assess risk factors from the age of 18 and an absolute risk assessment from the age of 30. So the previous guidelines said 35, and some but not all of the clinical decision support tools have been changed to an age of 30. And then right now we've got a clinical committee reviewing the guidelines, working with the Australian Chronic Disease Prevention Alliance, but this is mostly being led by the Heart Foundation. So they're working on that this year, and as I mentioned earlier, this is due for release in October next year. So most likely the major risk factors are not going to change, but the algorithm or the model behind the guidelines that we use may change. So they're currently assessing different models that we can use because we know the Framingham US model is quite out of date, but so far, we haven't been able to come up with an Australian model because our data linkage is very complicated in our health systems. So we're probably going to have to adopt a model from another country, and whether that stays Framingham or changes to something else is the focus of the current review process. Okay, so that's just a fairly brief overview of the guidelines that we're currently working with. And next, I'll present some research that we've been doing in Australia with a team of GPs, a cardiologist, biostatisticians, epidemiologists, and other behavioural scientists, just to get at what is going on with these guidelines and how could we improve the implementation of the next guidelines by learning from what went wrong with these ones. So for this work, we've taken a shared decision-making perspective on this issue. This is a fairly simple model by a colleague in Queensland, which positions shared decision-making as the intersection between evidence-based medicine and patient-centred communication skills for the purpose of optimal patient care. So when we look at CVD risk assessment in general practice, there are quite a few challenges for implementing a model like this. So in terms of evidence, we know the current guidelines are pretty out of date now. They're almost 10 years out of date, and GPs just don't have time to read and apply the latest evidence to every single health issue that you need to be across. So we need tools that quickly allow GPs to apply up-to-date evidence and guidelines to the patient in front of them. On the patient side, we know that people with lower health literacy need more support to understand issues like absolute risk and take action to reduce their risk. And in Australia, it's estimated up to 60% of people have low health literacy. So we've all had interactions with people who find it harder to understand the information that we're trying to convey, and we need strategies to convey that in a simpler way. So one thing that could address both of these issues is access to best practice patient decision aids. So these are tools designed to support shared decision making. There are international criteria on how you develop them to make sure that they're both evidence-based and balanced, and written in a way that patients can understand regardless of their health literacy level. So we know these work. There's been over 100 trials around the world. Cochrane reviews show that they consistently help. But in Australia, we've got really variable access to these. So probably the one you are most likely to have encountered is the PSA decision aid that the RACGP commissioned and has made available on their website. It's a very popular download. But that's just one issue. So we don't have a central repository for decision aids across lots of health issues that GPs are grappling with. And CVD prevention is one of those that we don't have access to currently. So all of this means that we're not doing too well with the implementation of the current guidelines. So the latest estimates we have, about 10 years after that initial assessment guideline came out, we've still only got 17% of patients having all their risk factors assessed in a way that would enable an absolute risk assessment. And we've got about 44% of patients being managed according to the guidelines in terms of who should get medication. So sometimes that may be appropriate, but because the numbers are so low, we think this is reflecting a failure of implementation. All right, just getting my, there we go. So when we started looking at this issue, it was actually 10 years ago that we started this. The guidelines were relatively new then. But we wanted to get a better understanding of how GPs were actually conducting CVD risk assessments and where the guidelines might help that process or where they might be not really practical for what the GPs are trying to do. So we started with an interview of 25 GPs and we identified different ways they were using these guidelines. So some GPs were using the absolute risk calculators when they considered it to be useful and appropriate for the patient. While other GPs would use it, but then they wanted to account for extra risk factors. So if the patient in front of them had a high BMI, they wanted to sort of adjust it a bit higher to account for that. Sometimes that's okay, but other times it can actually reduce the accuracy of the risk assessment. Other GPs prefer to just use their clinical judgment rather than an assessment tool when they thought that was as good or better than a calculator. And then there were GPs that had more practical barriers. So again, this was 10 years ago. Some GPs felt they just didn't have the time, the access to the tools or the experience in applying these guidelines to confidently do it yet. And then there were other times where absolute risk was actively rejected because they considered it to be unhelpful or inappropriate for the patient at that time. So that could be that the patient had come in with an acute issue that they needed to address in a short amount of time. There's just no time to fit in an absolute risk assessment. But it was also sometimes when they felt like conveying absolute risk would confuse or be unhelpful in some other way for the patient, particularly for those patients with lower health literacy. So we thought that some of these issues could be addressed through better tools for GPs. So as we get further down, we get further away from the guidelines, and as we get up, we go closer. But I just want to point out that sometimes there are very good reasons why you wouldn't apply the absolute risk guidelines. So this isn't definitively what you always can do in your practice. We also looked at the ways that GPs were communicating CVD risk because communication had come up as a particular challenge around the absolute risk guidelines in research in Australia and also overseas. We wanted to look into that in a bit more detail. So what we found was that GPs were using sort of 3 different tactics to deal with CVD risk with their patients in terms of communication. So for the positive strategy, the second column there, that tended to be used for people who had lower CVD risk. Maybe they were determined to make a change to their lifestyle, or they had a bit of concern about their heart attack risk and were open to talking about it. So here the aim of the GP was to reassure and motivate the patient. And they were able to use absolute risk tools to help with this. So if they knew it would be low, they could do the absolute risk assessment and show them, actually, your risk is only 2%, but you could even reduce that further by taking some action. On the other side of the patient spectrum, you have sort of the higher risk patients who maybe need more motivation or a scare tactic to get them to actually take it seriously and take some action. So this was particularly when the motivation was low or they were quite dismissive about the issue of heart attack and stroke. And the aim here was to sort of scare or motivate the patient into taking action. So the word scare came from the GPs themselves, but we'd probably, from public health point of view, say motivate. And again, the absolute risk tools could be useful for this. So here you could emphasise the high risk by using an absolute risk calculation and also show the future risk. So if the patient thought, 10% is not that bad, you could say, well, it's just going to keep going up. If we change your age to 10 years more, you'll see that it's gone up quite a bit, and we need to take action now to prevent that. And then finally, there was a more indirect communication strategy used for people who were, where the GP thought their risk was low now, but they had lifestyle risk factors such as smoking that they wanted to address. So they didn't want to demotivate the patient by showing them, say, a 2% absolute risk when they were trying to get them to quit smoking. So this was particularly where the patient was resistant to change, or also where they had trouble understanding complex issues such as risk, and also where the patient was overly anxious. So they didn't want to emphasise the risk for patients who were unnecessarily anxious about that already. So for this one, the aim was to avoid a negative or confused reaction from the patient, and they might use an absolute risk assessment, but not necessarily directly show that to the patient. So for that strategy, you need sort of different communication formats to address the aim of what the GP is trying to achieve. And the current risk calculators didn't provide that to GPs. So altogether, we had 3 different ways that absolute risk could be used for communication: to reassure and motivate patients, to scare them into taking action, or to avoid a negative or confused reaction they might avoid absolute risk calculators. So for the next study, we brought the patient perspective in. So we actually had a whole stream of patient studies trying to work out the best ways to communicate risk to them, which I won't have time to go into today. But for this particular study, we brought the GP and patient interview data together to get a better understanding of how decisions were being made around medication. So we had 3 main drivers of this decision making. One was perceived risk, but as I've explained already, this wasn't always based on an absolute risk calculation. So there was some risk there that they were missing some people who had high risk in the perceptions. The patient's motivation was a really important factor, and that had come up in the communication issues as well. And then the GP and patient's attitudes towards prevention medication, as opposed to a lifestyle change approach, also came in as a major driver of decision-making. So GPs tended to favour a lifestyle change approach when the risk was perceived to be lower, when the patient was perceived to be highly motivated, or when the patient was very resistant to the idea of taking prevention medication. So those 3 factors tended to favour a lifestyle approach, whereas a medication approach required a higher risk perception from both the GP and the patient. So that also relied on the communication, how well the GP could communicate the risk to the patient. Sometimes it was when the patient was lower motivation for changing their lifestyle. So the GP would maybe consider medication when they could see that this person's never going to quit smoking or change their diet. And then again, the attitude. So you needed either a positive or a neutral attitude towards medication to go with a medication approach. And that was for both the GP and the patient. So usually it was the patient who had a strong opinion about whether they would be willing to take medication or not, but sometimes it was the GPs as well. So we did have GPs who just philosophically felt like you need to try harder on lifestyle before we consider medication. So the key here was high risk perception. So if there was high risk perception and the patient was highly motivated, we get a lifestyle change approach. And if there's high risk perception and a reasonable attitude towards medication, you might get a medication approach. So this model is actually quite different than the algorithm that is provided in the guidelines. And so we do need to think about how patient values and in terms of motivation and attitude do come into play with medication decisions for this topic. Then the final study that I'll talk about was an experiment with GPs about how they make prescribing decisions. So this was with 144 GPs, and we presented them with 50 different cases where the absolute risk result and the individual risk factors for blood pressure and cholesterol either looked consistent or less consistent. So it was quite a complicated study. Each GP only got 12 of the cases at random. And what we were interested in is whether these new guidelines that had come out at the time, so this was published in 2014, and the management guidelines only came out in 2012, so they were relatively new. And we wanted to see whether we were starting to get an effect of absolute risk on the way that medication was prescribed. So if we start with blood pressure medication, you can see here that on the left, these cases had low absolute risk, but the blood pressure looked raised. So it wasn't high enough to warrant automatic medication, but it still was a bit higher than you would like. And here we were still getting really high prescribing rates, the same as if the absolute risk was high. So it looked like for blood pressure medication, it was really driven by the individual risk and not the absolute risk. But when we looked at cholesterol medication, there was starting to be a bit of a change. So here you can see that on the left, when the absolute risk was low, but the cholesterol was a bit raised, we were getting sort of half the rate of prescribing. So it looked at that time like the absolute risk guidelines were starting to be implemented for cholesterol medication, but not so much for blood pressure medication. So before I move on to the next session, I'm just going to show you a patient case that was given to us by one of the GPs in our interviews, and just get you to start thinking about what risk level you would think this person was and whether you would recommend any medications. And we'll come back to this in the next section. So Thomas is a male patient, age 69. His blood pressure is 135/79, total cholesterol 5.5, HDL 0.9, and no history of diabetes, smoking, or family CVD. So he's also really healthy. He's got a BMI of 22 and is a really keen bushwalker. So this is a real patient that one of the GPs described to us. And I'd just like you to think about how you would classify this person's risk. So in part 3, I'm going to talk about automated decision support as a possible solution to some of these issues around which risk factors do you include where, the combination of the assessment and the management guidelines, and also dealing with the communication issues for patients. So what we did first, before we went into a development process, we wanted to just see what was already available to Australian GPs. And we identified 73 different CVD risk calculators that they could access that were publicly available. So some of these were okay. They weren't really geared towards patients, even though they were public. So they were only moderately understandable and had poor actionability. So this was largely because medical terminology wasn't well explained, which wouldn't be an issue for a clinician, but would be for a patient. And it tended to just give the percentage risk result with no guidance on what that meant. So more of a problem though for GPs in Australia is that there were very few 5-year framing and base calculators available. So as I mentioned, most other countries use a 10-year model, and you can't just transfer the 10-year finding to a 5-year model because the guidelines don't match up that easily. In terms of patient decision aids to support more of a shared decision-making approach, we found 25. They were very understandable because they were designed for patients and they had moderate actionability about what to do about the risk. But key content features were not always included. So often they used this CVD acronym without explaining what that actually meant. If you don't explain cardiovascular disease can lead to important outcomes like a heart attack or a stroke, many patients actually don't make that connection. And more importantly, all options weren't included. So the decision aids tended to just focus on, should I take statins or not? Should I take blood pressure medication or not? And it didn't put them all together in the way that actually reflects our guidelines, including the option of lifestyle change. So altogether, although we found almost 100 tools, we weren't able to find any that met our criteria for matching the Australian guidelines and meeting the needs of different health literacy levels for the patient. So what we did next is we built a website, which is essentially an interface for the current guidelines. So it still uses the same risk model as the CVD check one that you might have used, or the one that's in best practice or medical director, but it incorporates extra elements from the management guidelines and our communication work. So this was done as a co-design process with GPs. Half the investigators on my project team are GPs, to make sure that this is actually relevant to what you do in clinical practice. So we started off with content testing amongst a group of 18 GPs who were involved in a monthly journal club small group learning session that we were running. We then built a prototype website that was presented to over 100 GPs at a GP conference, and we had a store there where GPs could actually test it out and give feedback, which was attended by 25 GPs. We then did more intensive end user interviews with both GPs and patients to make sure we weren't missing anything major. And actually, as a result of that, we ended up adding some extra features to the websites that GPs wanted, such as an alcohol audit and BMI calculation. And then we finally did some feasibility testing with a group of 100 GPs. So we asked them to use the website over the course of a month, and we tested whether using that helped them better identify guidelines. So what it looks like is it still gives you the percentage risk, but it gives you different risk communication formats. So there's lots of research showing that an icon array that turns an abstract probability into a natural frequency is a better way for many patients to actually understand what this 16% means. So instead of just using the percentage, you can say out of 100 people like you, we'd expect 16 to have a heart attack or stroke in the next 5 years. So that's linking it to an outcome that's actually important to them and giving them a visual representation of what that means. The tool also will apply the management guidelines. So if the person was clinically determined to be high risk, such as being age 60 with diabetes, it would come up to say that this person is clinically determined to be high risk, and you don't necessarily have to do an absolute risk assessment for those people. It will also tell you what the management guidelines recommend. So for this person, we've got smoking, diet, and physical activity. If they weren't a smoker, smoking wouldn't be shown. And because they're high risk, we've got both cholesterol and blood pressure medication recommended, but not aspirin, because at this stage that's not recommended in our guidelines, although it is in the US. So that's how we've sort of built in the assessment and management guidelines in a sort of patient-friendly communication format. And then to make the decision about what to do, we've got a decision aid. So this is designed as an interactive tool that a GP could use in a consultation to go through different options that they want to consider with their patient, and it will quickly apply the evidence to how much their risk could be reduced. So you can find this information in the literature and in the guidelines if you look at the references, but it's actually very hard for a GP in their head to remember how much exactly do different medications reduce a person's risk and do the maths to apply that to their risk level. So this tool does that for you. For this person, if they took statins, their risk would reduce from 16% down to 12%. So that's changing their risk category from high risk to medium or moderate. And we've also got like side effects and costs that the patient might want to consider before they took that option. So if this person was resistant to medication, you could instead show them the effect of stopping smoking, which would actually have a bigger effect on risk reduction, or look at diet or physical activity options. On the right-hand side, we've got various supplements. So this was actually feedback from the GPs we spoke to. At the time we developed it, there had been a big study suggesting that fish oil or omega-3 might be protective against heart disease. When you look at the data, it doesn't show that clearly at this point, but they wanted it in there so that if a patient asked them about it, they could click on that option and say, well, yeah, you could take multivitamins, but it's not actually going to reduce your risk of having a heart attack or stroke based on our current research. So that's where we're trying to provide the latest evidence to GPs in a way that they can quickly apply it to the patient in front of them. So coming back to our case study of Thomas, as I mentioned, this came from a GP who hadn't previously used the absolute risk calculators, but what made him start doing it is he happened to do a calculation for this patient, and he was really surprised to find that the risk was high. So the risk for this person is 17%, even though it doesn't look that bad. So the blood pressure is like a little bit raised, the cholesterol is a little bit raised, but the HDL is low, and because it's a ratio, that's sort of what's increasing the risk there. But he doesn't really have any other risk factors, and it's not until you apply the absolute risk model in a calculator that you realise how high risk this person actually is. So a quote from that GP: "You may have a bias into thinking that they have a lower risk than what they actually have. That's where using the calculator is helpful." And BMI often came up as an issue in those interviews as a reason to sort of adjust the risk lower or higher. But actually, when you account for blood pressure and cholesterol, the effect of BMI as an independent predictor disappears. So it was included in the framing model, but it dropped out because all of that effect was through blood pressure and cholesterol. So we presented cases like that to the GPs in our feasibility study, and we just wanted to see whether using our website would help them identify what the risk category was according to the guidelines. So the dark bars are what they thought before they used the website. So you can see that more than half of the GPs could identify the low and moderate risk categories we presented. But for high risk, because they were a bit counterintuitive, like the one I've just shown you, we had less than a third of GPs identifying those patients. So after using the website, we were able to increase all of the categories, but we were particularly interested in the high risk, which went from 29% to 78%. So as I mentioned, we were also doing a patient stream of research, and I'll just quickly show you what we came up with for patients so that they could sort of independently look at this information as well. So we have investigated the use of the heart age concept. You might have seen the heart age calculator that the Heart Foundation has been promoting over the last couple of years. But our research hasn't really supported that as an effective risk communication tool. So it's really effective for getting people's attention and having a strong emotional response, because no one wants to be told their heart age is 10 years older than them. But it doesn't do much in helping people actually understand their risk of a heart attack or stroke, or help them decide what to do about it. So we've dropped heart age from our consumer version, and we've just focused on that decision aid format again, but with a bit more explanation. So here's another example of someone who could use diet to reduce their risk. And then it goes through the benefits and potential costs of each intervention in a more sequential way, so they're not overwhelmed with information. We also have at the end of our patient calculator an action planning tool where they can come up with a really specific plan for what they want to do. So for this person, they have unhealthy snacks when they drink alcohol. So they've selected that as their sort of main trigger. And then their plan is going to be that if I want a snack because I am drinking alcohol, then I will eat fresh vegetables and dip. So that person had a plan that they were going to put dip and vegetables out whenever they brought out a bottle of wine, so that if they felt inclined to snack, at least it was more healthy than a bowl of chips. And there's quite a bit of research showing that these sort of if-then plans that are really, really specific are effective for behaviour change, particularly for people with lower health literacy. And then finally, the main feedback we got from the feasibility study was GPs were quite happy with the content of the intervention, but they wanted it to be better integrated into the workflow of a consultation, and particularly for the risk factors to be auto-populated from the patient record in the same way that best practice and medical director tools can do. So we have worked out a way to do that. The software systems are quite tricky in general practice, as I'm sure you know, because practices can choose different systems they want to use. But the best option we've come up with so far is to use PenCS Topper. So some of you may have used this before. When you have a patient record open in, say, best practice, like this example, you just click on the icon at the top and it will auto-populate the risk calculator and the decision aid. So we're currently trialling this software with a number of PHNs in Queensland, South Australia and New South Wales. It's not currently available in Victoria, but if you are interested in being part of our trialling of different software solutions, get in touch with me and I'll let you know what we're doing in your region. And then just another example of how we can use PHN software to implement decision support is via health pathways, which was mentioned at the start. So this is an example of a health pathway in New South Wales that we've been tracking over the last year. And you can see that the use has dipped down during the first COVID lockdown before Victoria had their extended one. So I'm sure Victoria would look quite different to this. But we're just tracking over time how much these health pathways actually get used and whether that might be an effective way to implement the new algorithm when it comes out next year. Excuse me. So the last section is going to be on future directions for CVD risk assessment. So I don't have a lot of time to go into detail here. There's lots of really exciting research being done in this space. But I will show you just a few things that are happening in Australia. So firstly, in terms of international guidelines, as I've mentioned, the medication thresholds are really different in different countries because we're using different models. So Australia and New Zealand are in the minority in using 5-year risk models, whereas the UK and the US use 10-year risk models. So we can't really compare the guideline thresholds very easily. But the general trend is that most countries that have reviewed their guidelines since ours came out have tended towards lowering the medication threshold. So if we take the UK as an example, they've reduced their threshold for statins from 20% risk over 10 years down to 10% over 10 years. So it is a different risk model, but that also represents a huge expansion of who you can prescribe medication to. And a similar trend was in the US. So they've reduced even further down to 7.5% over 10 years, which is very low. So that means a lot of our currently low or moderate risk patients would be classified as high risk in these other countries. So just to give an example of that, the table on the right at the top, you can see the proportion of women aged 40 to 74 who are classified as high risk under our current guidelines is only 2%. It's a bit higher for men at 17% because sex is a major risk factor for CVD. If we apply the same population data to the US model, that would increase for women from 2% to 18%, and for men it would increase from 17% to 46%. So if we applied the US guidelines here, half of men in that age group could be prescribed medication. So that's a really big change, and it's something that may come up in the new guidelines next year, that we have wider prescribing thresholds. Or we might take more of a New Zealand approach and have a wider moderate risk category where a shared decision-making approach is advocated. So then it becomes really more about the patient preference in terms of, do they want a lifestyle change approach or do they want to consider medication? So we're not sure which way that's going to go for Australia, but that's something that may happen. If you want to read more about it, you can read a paper that's linked here. So this is an overview of CVD risk assessment and future directions by my colleague Jenny Doust, a very clever GP and epidemiologist. So in that paper, she also outlines a few different approaches that we might use to supplement risk assessment in future. So this is things like the ankle brachial index, coronary artery calcium scoring, high sensitivity C-reactive protein, and resting or exercise ECG. So ECG is already part of the Framingham risk guidelines, but there's still very limited data on how you use that. But it looks like coronary artery calcium scoring might be the next one that comes in, particularly after this month, the Heart Foundation has released a new position statement on that. So I'll just talk a little bit more about that one because it's the most likely one that you will come across in your practice, and you may have already used this. So the rationale here is that absolute risk assessment is better than individual risk assessment, but it still misses some cases of heart attack and stroke. So we know that atherosclerosis develops before CVD, and a CT scan can identify calcium in the arteries that maybe will pick up some of those cases earlier. So in the US, it's used to reclassify the intermediate risk. So that category where you're not sure whether to prescribe medication or not, you could consider referring for a CT scan, particularly if they have extra risk factors. And the recent position statement from the Heart Foundation seems to be advocating that approach, but it's not clear whether that's going to become part of the new guidelines or not, because the evidence behind that recommendation is low to very low. We just don't know that much about it yet in terms of patient outcomes. So the scan looks something like this and looks at the lesion areas and how big they are. And then there's different ways that you can classify what that means. So in the previous statement from the Cardiac Society of Australia and New Zealand, you wouldn't consider medication if it's 0 to 100, but beyond that, you might consider medication at different levels. So this is a bit in contrast to the absolute risk guidelines, and it's not totally clear how these two fields are going to merge together in the next one. And then I'll just mention one other approach that will be tested in Australia over the next 5 years is polygenic risk scoring. So this is, again, getting at how do we find those cases that are missed by absolute risk assessment. We know there's multiple genetic variants associated with CVD, but we don't always understand the mechanisms for that yet. And we know that genetic testing can be done at any age, so you could pick it up maybe even at the age of 20. So there is going to be an Australian study that incorporates both calcium scoring and polygenic risk scoring to reclassify some of those low to moderate risk patients and try to identify more high-risk cases. So in conclusion, just coming back to the shared decision-making model that we've been using, we hope that providing GPs with better tools to apply the evidence and the guidelines to their patients might improve the implementation of the next guidelines when they come out, and we're working with the Heart Foundation and the RACGP to try to do that. We also want to enable patients to understand their risk and actually act on that to change their behaviour. And we've demonstrated that we can use PHN software as one way to implement those decision support tools, although that's still a work in progress for our research program. So altogether, we've got potential to improve the management of 56% of patients according to the current guidelines. So hopefully providing those tools to GPs and other primary care professionals will help us achieve that for the next guidelines. So I'll finish there and I'll just leave up these links in case you want any further information about anything I've spoken about today. Thank you so much.
Thank you so much, Carissa. It's such important work, isn't it? And really, I think, yeah, we could do a lot better in. It'd be great to have one that we can use, but both for us to pick up people that you know, we haven't realised they're high risk, and also to be able to communicate that risk. So that's really fantastic. So, and can we use that, you know, you put up a website there that had that risk calculator with the boxes. Can we use that now?
Yeah, so the website's publicly available. So it's just
okay.
uscvdrisk.com.au. Anybody can use it. But the top bar app to auto-populate from patient records is currely being
that part, but we can access that risk calculator. Yes. Now, we've got some questions here from Arthur. A couple of years ago at this conference, a geriatrician told us BP in elderly folk was okay up for readings of 160 over 80. We all woke up at Sorry, there's another that disappeared. We all woke up at that info point. Outdated info.
Yeah, the blood pressure guidelines have changed a lot over the years, and it's a bit confusing in Australia because you've got the absolute risk guidelines and then you've got the hypertension guidelines, and they actually don't match up. So our current guidelines say that if it's over 160 consistently, then you should automatically put them on medication, but it's trickier for the older age group.
Yes. If they're fainting, obviously.
Yeah.
But we should be treating it if they can tolerate. Anonymous, is the Oz-RIC-CV referred to in the health pathways? And Katrina's already answered that, saying it's included on the pathway. So yes, so we can find it on the pathways, which is very useful. Good question. Anonymous asks, are non-fasting cholesterol levels acceptable? Many patients don't like the fasting tests.
Oh, that's a good question. And beyond my knowledge, that one, sorry.
Yes, I often use that with patients who don't want to fast, and I don't know whether that's correct, but yeah, rather than the 10 hours. Yeah. Anyway, I don't know if anyone else out there has got an answer to that, but if you have, put it in the questions if you can. Anonymous asks, I thought we weren't meant to be using statins in primary prevention, but this is different to the example given.
So statins are recommended in primary prevention, but aspirin isn't. So aspirin is sometimes considered for if there's a combination of CVD risk reduction and bowel cancer risk reduction, sometimes aspirin is used, and it's also recommended for certain coronary artery calcium scores in the Cardiac Society statement. So if you're just going by the absolute risk guidelines in Australia, aspirin is not currently recommended. That'll be part of what's reviewed in the new guidelines because it is very variable. It does reduce risk, but it has a high side effect risk of gastrointestinal bleeding. So it's one of those ones where the balance is a bit unclear.
Mm-hmm. It is fine for non-fasting. Oh, that's about the cholesterol. Yep. Okay, that's good to know. Paul Egan asks,
it's just cut out for me, Anne. I'm not sure. Yeah, no problem. I'll just, I think Anne's dropped.
Yes.
Oh, oh, you've frozen it. Okay, I'll just have a look at the questions myself. The moderator's just told me to start answering the questions, Anne, if you can hear me. I'll just see where we were up to. Okay. Yep, so a lot of those links have been put into the chat. I actually can't see the questions.
I'm back. Yeah. So the last question was coronary calcium scores likely to attract a Medicare benefit from Paul
Yeah, that's
Egan.
a really good question. At this point in time, no. So patients have to pay out of pocket for it, and depending where some places it's not even available, but where it is, you can usually get it for around $200. I think it's unlikely that it's going to be put on MBS anytime soon because the grade of the evidence behind it is so low. So until we get more trials showing that it works, I think it's unlikely to be in the near future.
Mm-hmm. And it's in around the $250, I think, the last I heard. Anonymous asks, is there still a heart health assessment MBS item?
Yes, there is. It's been extended. So that was an unusual item that came through. It should have had more consultation with GPs in the way it was put through, but it was a bit of an election thing. So it was a temporary item for a year. It's just been extended. But I think the Heart Foundation is working to make it more useful for GPs because I know for a lot of practices it doesn't work well with your business models. So it can, depending on how you work and if you get practice nurses involved, but sometimes it makes more sense to use a different item.
Yep. Jenny Huang, it is re-TG, which might be therapeutic guidelines. So if if that is raised in a non-fasting test, then I do let patients know will benefit from fasting. Maybe that's triglycerides. I think that she's talking about triglycerides. So I don't think that's a question. I'm just going to get rid of that. And that, yep. So Anonymous asks, I understand exercise is better than statins at decreasing risk. How is that fitted in the calculator?
Yeah, so if you use the decision aid part of the website, it's pretty similar between medication, physical activity, and diet, but that's only if the patient is doing it in the optimal way that was shown in those studies. So diet particularly is tricky because it's a Mediterranean diet, and exercise, the study behind that was comparing quite an intensive regimen of exercise. So, I mean, anything is better than nothing, but if you want to get the full benefit, they really need to be doing quite a bit of exercise.
And I think this is pretty quick, this question. The male case presented, would a statin be PBS subsidised?
Oh, that's a good question. So there was an issue where the statin PBS criteria did not match the absolute risk guidelines for many years, and that was part of why it was implemented poorly. But my understanding is that's been addressed now, so that if you have a high absolute risk, it should be subsidised, but I would have to double check that.
Yep. Thank you so much, Carissa. We've run out of time. I didn't say last time, please, everyone, can you fill out your evaluation at the end of this? It really takes about 30 seconds and really helps us with planning, and it also helps you win a prize. So we'll see you in the next session. I think we have a bit more of a break now until 12:10. And thanks again, Carissa, for really taking
No problem. Thank you, Anne.
No worries.